Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our new series entitled The QME's Clinical Rounds, and today we're in session 4 of this series. And this is a fascinating series of discussions related to common conditions, common neuromusculoskeletal conditions that you're going to encounter in your career as a qualified medical evaluator. And I'm going to step out on a limb and venture that you're probably going to encounter at least one of these clinical conditions in your very next, say, 5 evaluations. These are conditions that are prevalent both in the general population and certainly in the injured worker population, which is the pain population. And we're talking about conditions that are known pain-generating conditions. And so these are the types of conditions that are going to be frequently and easily injured in the industrial setting. And because these conditions are known to cause pain, and because pain brings people and injured workers in for medical treatment, these are common conditions that are encountered both in the clinical setting and certainly in the industrial setting. And today we're in session number 4. And in session number 1 of this program, we talked about a very common condition that you're going to encounter as a qualified medical evaluator in those cases that involve extremity injuries, particularly repetitive motion extremity injuries. And that has to do with carpal tunnel syndrome. And we focused our discussion in that session about the pathognomonic observation, the pathognomonic clinical finding that when it's present will tell you with a 93%, a very, very high percentage likelihood that the condition that the examinee is explaining to you and the condition that the examinee is suffering from is a true and bona fide carpal tunnel syndrome condition. And on the other hand, when this pathognomonic finding, the flick sign, known as the flick sign, is absent, there's a very, very high likelihood that the symptoms and the condition that the examinee is describing to you, while it may be present, is not due to bona fide carpal tunnel syndrome. So the flick sign is a very, very valuable clinical observation that you should tune your awareness to observing either for its presence or for its absence in your carpal tunnel syndrome cases. In session number 2, we got into a discussion about spinal injuries and the clinical finding of Schmorl's nodes. And we talked about the pathoanatomy of Schmorl's nodes as the nucleus pulposus fractures through the end plate cartilage and then through the cancellous bone of the vertebral end plate of either the vertebrae above or the vertebrae below, or in some cases of both vertebrae. And then we talked about some of the permanent impairment rating options that you have available to you for rating these examinees who have had either vertebral end plate fracture as a result of the industrial injury, or when in those cases where the examinee has had Schmorl's nodes and has had prior spinal injury and then has an exacerbation or an aggravation of that pre-existing condition, we provided for some permanent impairment rating options available to you under both the DRE and the range of motion methods of rating spinal impairments. In our last session, which was actually a double session, we talked about the very, very common condition of rotator cuff tendinopathy. And you're going to encounter 3 cases of rotator cuff tendinopathy in your next 10 QME evaluations. That is, if you're a neuromusculoskeletal evaluator like I am. Because this is a very frequent problem because of the nature of the shoulder joint itself. You know, the shoulder joint's a fascinating joint. It's a mobility joint. It's not a weight-bearing joint. And yet we insist on loading up with weight the shoulder joint. And so the shoulder tendons, and specifically the tendons of the supraspinatus and the infraspinatus, quickly can become overwhelmed, and the internal homeostasis of the internal environment of the tendon can become upset, and very quickly the health and the integrity of the tendon begins to deteriorate and degenerate, and we refer to that condition as tendinopathy. We no longer use the term tendinitis because histologic studies of painful tendons reveal an absence of inflammation and an absence of inflammatory cells within the painful tendon. So tendinitis, which refers to inflammation of the tendon, has become a discarded term, and the new term used to describe painful tendons and degenerative tendons is tendinopathy. So like we did for Schmarl's nodes, we provided for some permanent impairment rating options for you to use in those cases where your examinee has suffered a shoulder injury and at the permanent and stationary evaluation is left with some loss of strength, loss of range of motion, perhaps has some instability of the shoulder due to inhibition and hypotonicity of these muscles. And in those cases where the examinee has undergone a surgical procedure, we provided some permanent impairment ideas for you to incorporate into your final permanent impairment opinion related to resection of the distal clavicle under the strict application of the AMA guides, or by analogy to resection of the distal clavicle under Alvarez and Guzman for those surgical procedures that do not involve the exact procedure of a resection of the distal clavicle. So that was a fascinating discussion, and that brings us to today's discussion, and I have another fascinating discussion for you today related to cervical ribs. Now, I know you've heard of cervical ribs, you've seen cervical ribs, you've had cases, patients who have had cervical ribs, and you're well familiar with the radiographic finding of a little nubbin, a little bone nubbin of varying length coming off of the transverse process of C7. And in some cases that little nubbin is simply an elongation of the transverse process of C7, and in other cases that nubbin forms an articulation with the transverse process of C7, in which case that particular nubbin is referred to as a cervical rib. So both elongation of the transverse process of C7 and a true cervical rib can cause many, many complications, and I know that you're well aware of these. But what I want to share with you in today's discussion is a little bit of a different twist on cervical ribs, and it has to do with how cervical ribs, because of this extra supernumerary and extra osseous structure attached to the ribs, which is then in itself variably attached and fixed to the normal first rib, how this fixation at the cervical-thoracic junction can impact our analysis for motion segment integrity in those cases that involve a cervical spine injury. So as you know, with examinees who suffer a cervical spine injury, when they become permanent and stationary, one of our obligations as a qualified medical evaluator is to evaluate the examinee for the absence or the presence, or I should say that in reverse. Our obligation is to evaluate the examinee for the presence or the absence of every single one of the cervical spine impairments that are described in the AMA guides. So as a qualified medical evaluator, we're obligated to assess our examinee for permanent impairment due to alteration of the normal motion segment integrity of the individual vertebrae of the cervical spine. Well, how could the presence of cervical ribs impact motion segment integrity of the lower cervical vertebrae of C6, of C7, and even of T1? It's possible that this additional fixated segment down at the C7 vertebral segment could alter what the AMA guides describe as normal intersegmental motion. So what I want to do today is I want to share with you a case where an injured worker suffered a cervical spine injury as a result of a front impact auto accident. And lo and behold, on X-ray study, the examinee was demonstrated to have the pre-existing condition of bilateral cervical ribs. So in today's discussion, we're going to review the pathoanatomy of cervical ribs, and then we're going to go through the actual analysis of motion segment integrity and see just exactly how this examinee suffered loss of cervical spine function as a result of injury, and the loss of function of the cervical spine was rated according to the DRE cervical category 4 for loss of spinal motion segment integrity. So with that as our introduction, let's get into today's discussion, which has to do with cervical ribs and the impact of cervical ribs on your permanent impairment ratings. Okay, so let's go over some of the anatomy of these cervical ribs. So cervical ribs, as you know, are anomalous, are supernumerary, are extra or additional ribs which arise from the 7th cervical vertebrae. Now, cervical ribs can arise from any of the cervical vertebrae because cervical ribs arise from mesenchymal tissue that's present in each of the cervical vertebrae. But most commonly, they arise from the 7th cervical vertebrae. But don't be surprised if you see a cervical rib at the 6th cervical vertebrae, or even as high as the 3rd and 4th cervical vertebrae. The studies seem to vary on the prevalence of cervical vertebrae in the general population. Some studies suggest it's low, about 0.5%, so that's 1 in every 200 people may have a cervical rib. Other studies indicate it's much, much higher. It's 10 times higher than that, with as high prevalence as high as 6.2% of persons presenting with some form of a cervical rib. Now, cervical ribs are described in studies differently. Some studies describe cervical ribs as commonly bilateral. Other studies, on the other hand, describe cervical ribs as more commonly unilateral. So studies seem to differ on the laterality of cervical ribs, just as the studies differ on the prevalence rates of cervical ribs. And most studies seem to indicate that when they're unilateral, they more commonly occur on the right side. Cervical ribs in general are more common and more frequent in women. And when they're bilateral, they're commonly asymmetrical, meaning not having the same size and not having the same type of attachment to the first rib. So let's take a look at some pictures of these cervical ribs so that we get a good mental image picture of the anatomy of these particular structures. Okay, so here we have a couple of diagrams of cervical ribs. So let's just get our orientation and our bearings. On the right here, we have an X-ray image which depicts the presence of cervical ribs, and in this case, these are bilateral. And as we discussed in the previous slide, you can notice that they are indeed asymmetric. And these are arising from here, the 7th cervical vertebrae. Here's the 6th cervical vertebrae. So if we look at an anatomy specimen, this is how the cervical rib looks anatomically. Here we have C7, here we have T1, with the normal first rib arising by way of articulation here, with the transverse process of T1 here, and here is the articular line here. Now, the anomalous or supernumerary cervical rib arises from C7 here, and what we don't typically see in the X-ray radiograph over here, but which sometimes shows up better on MRI, are extensions off of the cervical rib in the form of fibrous bands. And these fibrous bands make various and variable connections of the 7th rib to the first rib. Now remember that anatomically, this area here in the anterior aspect of the first rib is where the anterior scalene muscle is going to make its attachment here as it comes down from the transverse processes of the upper cervical vertebrae. And then the middle scalene is going to make its attachment here, again arising from the anterior aspect of the transverse processes of the upper cervical vertebrae. So this cervical rib narrows the scalene triangle, and remember, through the scalene triangle goes the entirety of the brachial plexus and the subclavian artery. The subclavian vein passes anterior here to the anterior scalene muscle. So a cervical rib very quickly crowds the scalene triangle here. And remember that anatomically, the nerve roots in the cervical spine are named for the vertebra above. So here we have the C8, or named for the vertebrae below. So here we have the C8 nerve root coming out. Between C6 and C7 here, we have the C7 nerve root coming out. And then here we have the T1 nerve root coming out. So it's the C8 and the T1 nerve roots that are going to be most affected by their course over this fibrous band or over this anomalous cervical rib, and that's going to contribute to variable symptoms of either a neurologic component, of a vascular component, or of an arterial component. Now, there are various theories as to why cervical ribs would persist and why the cervical rib would not be reabsorbed and disappear, as is the typical scenario. But anatomically and embryologically, the ribs are derived from the ventral extension of the sclerotomic mesenchyme that forms the vertebral arches. So remember that the vertebrae are formed from the sclerotome, and the sclerotome derives from the paraxial mesoderm. So the ribs are mesodermal tissue. And so, for example, here we have an example of a cervical vertebrae. This is dorsal here. This is ventral here. So here we have the ventral extension of the mesenchyme that forms the vertebral arches here. So this is the ventral extension. And in blue, this blue segment is referred to as the costal element. And all regions of the spine, all four regions of the spine, contain various sizes and various stages of development of these costal elements. They're ventral to the mesenchymal basis of the transverse processes. So here is a transverse process. Here is a transverse process in the cervical spine. Here is a transverse process in the sacral spine. So in every single case, these costal elements lie ventral to the transverse process. Now in the thoracic region, the entire extension, the entire ventral extension undergoes first chondrification, and number two, later undergoes ossification to form the ribs. And there's various theories as to why the ribs develop in the thoracic spine compared to why they fail to develop in both the cervical and the lumbar spines. And we'll touch upon that in just a moment. Now, some of the mesodermal tissue forms the costotransverse joint between the developing rib and the transverse process, and embryologically, these extensions are referred to as the costal elements. In the thoracic spine, the costal elements become the bone, which is formed from the primitive costal arch and becomes fused with the transverse process. And in the cervical spine and in the lumbar spine and the sacral spine, these costal elements fail to develop into ribs. They simply resolve and become reabsorbed and become just a part of continuity with the transverse process itself. Okay? So let's take even a closer look at the relationship of the cervical rib with the neurovascular structures at the thoracic outlet. Okay, so now we have here our same diagram that we saw earlier, but in this case the diagram is a little bit more developed to show the anatomy. And here we have our cervical rib as we saw before, but now overlying and adjacent to the cervical rib, we've now placed the anterior and middle scalene muscles. And here we show the relationship of the subclavian artery to the anterior scalene muscle and the cervical rib here. And what this diagram is depicting is potential compression of the subclavian artery here, subclavian stenosis, with a post-stenotic dilatation of the subclavian artery here. Now clinically you may note this as a pulsatile mass in the supraclavicular fossa of your examinee, or you may feel this as a palpable pulse in the supraclavicular fossa of your examinee. Okay, so that's one anatomic relationship. Now here in this diagram now introduces the brachial plexus, in this case originating from C5 through T1, as is the typical anatomy. So with the typical anatomy of the brachial plexus, notice that the lowest chord of the brachial plexus, that involving C8 here and T1 here, is elevated as it passes over the cervical rib, and this can be a source of neurologic compression due to cervical rib. Here we have a case of vascular compression due to cervical rib. In this case, we have an example of neurologic compression of the cervical rib. Now, there are various theories as to why cervical ribs persist in certain persons and why cervical ribs disappear and become resorbed in the large majority of persons. And one theory has to do with the anatomy of the brachial plexus. The anatomy of the brachial plexus. So I want to read a couple of citations for you from a study that addresses this particular issue. And I'm reading for you now from a study entitled "The Ossification of the Costal Element of the Seventh Cervical Vertebra with Particular Reference to Cervical Ribs." So this is talking about when the costal element first undergoes chondrification and then ossification rather than resorption to become a true cervical rib. And I'm reading from this study now, and they tell us that during embryologic development, each body segment contains both a spinal nerve and mesodermal tissue, which will later form a rib or will form the costal element of a vertebra. In limbless animals, such as a snake, a rib will develop at each body segment, Well, in humans, the development of limbs necessitates a crowding together of a number of segments with their associated spinal nerves. This is crowding that's not required in limbless animals. Okay, this is relating to limbed animals. It is therefore suggested that in the cervical and the lumbar regions, the developing nerve takes precedence over the rib, so that development of a rib at these levels is prevented. So in the case of a normal brachial plexus, C5 through T1, normally the development of a C7 cervical rib is prevented. That's why such a small percentage of people are found to have cervical ribs. So they continue to tell us that when there is a large contribution to the brachial plexus from the second thoracic spinal nerve root, in other words, from a spinal nerve root down in here, as depicted in this diagram, we have a contribution from T12 to the brachial plexus. In this case, a rudimentary or deformed or shortened first rib results. And this diagram is depicting a rudimentary shortened first rib. Notice that there is no continuation of the first rib to attach out here to the manubrium of the sternum. This is a rudimentary first rib, the theory being that this rib is prevented from developing to give space and preferential treatment, preferential space for the T12 nerve root, which is contributing to the brachial plexus here. So this is referred to a post-fixed brachial plexus. Post-fixed meaning that the brachial plexus derives its anatomy largely from C6 through T2 as opposed to C5 through T1. Conversely, this study suggests that where there is a limited contribution from the first thoracic root, limited contribution here from T1, in other words, we have a prefixed brachial plexus. Okay, here this is a post-fixed brachial plexus. A prefixed brachial plexus derives its innervation from C4 typically through C8 with either absent or minimal contribution from T1, and then this allows a persistence of a cervical rib here at C7. So they tell us that where there is limited contribution from the first thoracic root, cervical ribs are allowed to persist. So very, very fascinating. It was initially thought that cervical ribs existed only in persons with a prefixed brachial plexus, and rudimentary ribs were found in those particular autopsies or cadavers that had post-fixed brachial plexus. But then later on, further studies and further researchers disagreed with this finding because cadaver dissections of many cases showed normal configuration of the brachial plexus, even in the presence of cervical ribs. So the researchers concluded that the development of the nervous structures, in other words, neural development, alone was not sufficient to account for the condition or the development of the ribs. In any event, in the presence of cervical ribs, we commonly see clinically one or more of three types of thoracic outlet syndrome. And we're not going to discuss thoracic outlet syndrome in this discussion because I want to get into the analysis of motion segment integrity. But just to refresh our own memories, there's three basic descriptions of thoracic outlet syndrome, specific for the type of tissue that's involved in the compression. So most common tissue compressed in thoracic outlet syndrome is the brachial plexus. So in 95 to 98% of cases of compression within the thoracic outlet, 95 to 98% of those cases will involve compression of one or more of the nerve roots of the brachial plexus. Now, of these 95 to 98% of cases, the true or classic neurogenic thoracic outlet syndrome is present in only 1% of cases, and it's defined as true or classic if it carries with it true positive objective findings. Much more common, 99% of all cases, is the non-specific or the common neurogenic thoracic outlet syndrome, which involves no objective findings. So don't be surprised on your physical examination if the typical maneuvers that you employ to assess for thoracic outlet syndrome do not provide true positive objective findings. The other classifications of thoracic outlet syndrome include arterial thoracic outlet syndrome, wherein we see compression of the subclavian artery, which passes specifically right through the scalene triangle and right immediately posterior to the anterior scalene muscle here. And then we have also venous thoracic outlet syndrome, which involves compression of the subclavian vein. And the subclavian vein passes here anterior, let's draw it in blue, anterior to the anterior scalene muscle. So it doesn't pass through the scalene triangle, but it does pass through the costoclavicular space as the clavicle traverses here laterally from the sternoclavicular joint here, laterally in front of the first rib. So the subclavian vein passes through the costoclavicular space but does not pass through the scalene triangle. So with thoracic outlet syndromes, depending upon the particular structure that's compressed, will determine the type of symptoms that the examinee reports to you. Typical symptoms of vascular arterial compression include a diminished or an absent radial pulse. With neurologic compromise, we're going to encounter reduced sensation, reports of numbness and tingling, particularly in the ulnar aspect of the forearm and hand, due to irritation of the C8 and T1 nerve roots here. And then examinees will report a painful and weakened hand. There may sometimes be a palpable or pulsatile mass in the supraclavicular fossa. And depending upon your examinee's description of symptoms, will give you a good idea as to which of the structures are being compressed at the thoracic outlet. Okay, so here we have an x-ray of an actual examinee in the workers' compensation system. And this is the cervical x-ray of a 40-year-old delivery driver. This is a driver of making deliveries of auto parts, and the delivery driver was driving the company vehicle, which was a small compact vehicle, and he entered an intersection, and surprise, surprise, from the right another vehicle ran a red light and came into the intersection, and the examinee struck the other vehicle head on. So this is a case that involves a front impact cervical hyperflexion injury. So x-rays reveal the presence of cervical ribs here, right down here in this area. And you can see this is the transverse process of C7. There's an articulation here with a small costal element projecting beyond the transverse process of T1 here. And this is a cervical rib. And then on the other side, you'll see that the finding is bilateral. So let's indicate these cervical ribs right here. And we have a measuring tool, which might not be the best tool, but I want to draw an arrow that points to those cervical ribs. Okay? So the examinee has bona fide pre-existing condition of cervical ribs. So the examinee underwent a period of medical treatment and was declared to be permanent and stationary. And let's see how the analysis of motion segment integrity was impacted by the presence of these cervical ribs. So here we have our cervical flexion radiograph, and you can notice right away that range of motion of the cervical spine in flexion is somewhat restricted. In other words, this is not the lateral cervical radiograph. This is the flexion radiograph. So let's take a look at the analysis of motion segment integrity. We grab our Cobb angle measuring tool here. We draw a line through the anterior and posterior tubercles of C1, and then across the inferior end plate of C2, and we measure the angle. Now I want to say a couple of things about your analysis of motion segment integrity, and that is you need to pay particular attention to positive and negative angles. So when the cervical spine is in a typical lordosis, all of these end plate lines will converge posteriorly. And you can see that these two angles are going to converge somewhere out here posteriorly. When the end plate lines converge posteriorly, the angle by convention is given a negative numeric value. So in this case, the numeric value of this angle is negative 6.6 degrees. Okay? And then we continue to make our measurements by moving the end plate lines down to the next vertebra. Again, we use the inferior end plate and then the vertebra below. Now we're doing the analysis at C2, C3. And we capture our angle. And notice now that the end plate lines are diverging posteriorly. Instead of converging posteriorly, they're diverging posteriorly. So this is, by convention, this is a positive angle. So this is a positive angle of 7.1 degrees. And then we continue with making our assessments down the cervical spine, measuring the flexion angle at each individual motion segment of the cervical spine. And then we do the same thing with the extension radiograph. We make our extension angles with the same method using the inferior end plates. Notice this is a negative angle, and the angle went from minus 26 degrees on the flexion radiograph to minus 33 degrees. And then we just continue the same measuring system all the way down. And I won't take our time here during this discussion to show the measurement of every segment, but let's just go directly to the chart where we provide our findings and our angles on each of the segments of the spine, and then we'll do the analysis of motion segment integrity. Okay, so here are our findings. In the first column here, coming downward, we're going to provide our findings on the flexion angles at each of the spinal segments, beginning up at C1 and ending at C7. And remember, this is the area here wherein we have the presence of the cervical rib, the anomalous cervical rib at the C7 vertebra. So the C1, C2 flexion angle was minus 9.9 degrees. As the spine went into extension, the extension angle was minus 35.6 degrees. And then we simply plug these values into the formula provided for by the AMA guides, where we take the flexion angle and we subtract from it the extension angle to come up with the total angular motion at that particular spinal segment. So this particular spinal segment is demonstrating approximately 26 degrees of total angular motion as the cervical spine at C1, C2 goes from the extreme of flexion all the way to the extreme of extension. This particular motion segment has a range of motion of approximately 26 degrees. Now the AMA guides do not provide for normal values for C1, C2. So over here in this column, where we provide our analysis of the motion segment integrity, I've indicated simply NA, that there are no applicable values for this particular segment of the spine. And we'll fill in our analysis here in our next slide, but for this slide, let's just provide our angular motion findings. So at C2, C3, we have a total angular motion of 11.3 degrees. At C3, C4, the spine goes from plus 5.1 to minus 3.2 for a total angular motion of 8.3 degrees. Now, let me make a note here. When you're reviewing your own numbers, your own flexion and extension angular measurements, realize that as the spine goes from flexion to extension, the angular motion values should go increasingly negative. In the extension angular motion column, these values should be increasingly negative compared to the flexion angular values. So let's just review our numbers so far and see if that is indeed occurring. So here we start out at minus 9.9 and we end up at minus 35.6. Indeed, we are becoming increasingly negative as we go from flexion to extension. Here we go from 5 degrees to 6.3, and again we're becoming increasingly negative. From 5.1 to minus 3.2 is increasingly negative. So we're seeing here at these upper levels of the cervical spine proper angular motion relationships as the spine moves from the extreme of flexion to the extreme of extension. At C4, C5, we have 6.7 degrees of total angular motion, and indeed we go from minus 0.9 to minus 0.76, so we're becoming increasingly negative. And then at C5, C6, we have only 1.7 degrees of angular motion, and I've highlighted this in red because there's a problem here, because we find that our flexion angle was minus 5.9, but our extension angle is only minus 4.2. So in actuality, this motion unit of C5, C6 is actually moving in the opposite direction. This is 4.2 is not increasingly negative compared to minus 5.9. In fact, it's increasingly positive. It's moving towards 0, which is towards the positive direction. So this segment of the spine is showing what's referred to as anti-directional or opposite or aberrant motion. This segment of the spine has obviously been injured as a result of the front impact collision and is lax and is loose and is not moving in the proper direction, and this is going to qualify for a permanent impairment rating. Now, if you were to measure these angular measurements yourself, you might come up with slightly different values. You might come up with something slightly different than 5.9. You might come up with something slightly different than 4.2. And if these numbers were slightly different, it's possible that your number could approach 0. In other words, 1.7 is just a little bit above 0. If your number came in at 0, that would indicate 0 total angular motion at this particular vertebra. My measurements came up with an opposite anti-directional aberrant motion, slight aberrant motion of 1.7 degrees. You might come up with something different. You might come up with 0 degrees. In any event, whether you come up with anti-directional movement or normal directional movement or even 0, all of the values would be close to 0, which indicates an absence of motion at this particular spinal segment. And even anti-directional movement of 1.7 degrees is only tiny motion. It's almost 0. It's almost 0. And then at C6, C7, we have actually 0 degrees of spinal motion. So at least at the last two levels of the cervical spine, something's going on. We have either an absence of motion with the possibility even of some anti-directional or aberrant motion occurring at the lower cervical segment, lower cervical spinal segments. So what is the analysis on this? Here in this particular table now, we're going to fill in this column where we provide the reader of the report our conclusion regarding the examinee's intersegmental spinal motion. So because the AMA guides do not provide normative values for the C1, C2 segment of the spine, we indicate here that there is no applicable standard against which we can compare our examinee. At C2, C3, I concluded that the intersegmental spinal motion was normal, and I'll show you those references from the AMA guides here in just a moment. At C3, C4, I concluded that the intersegmental spinal motion, although it was slightly reduced, I described it as normal because, as I said earlier, these measurements can vary, and sometimes when you're doing analysis of motion segment integrity, the intra-examiner reliability can sometimes vary. In other words, when you redo your very own measurements a second time, you can come up with different values, and the inter-examiner reliability may sometimes be low as well, where another evaluator makes measurements and comes up with values different from those that you provided. So even though 8.3 degrees of intersegmental motion at C3, C4 is slightly reduced compared to what's described in the AMA guides, I still considered it to be within normal limits. It's certainly indicative of some preserved spinal motion at this particular segment. Now, because intersegmental motion is expected to increase, as total angular motion is expected to increase as we descend in the cervical spine, we should see a trend of increasing angular motion measurements. And here at C4, C5, we see a value slightly less than at C3, C4 and less than at C2, C3. So I describe this as a decreased angular motion at this particular level of the spine. And that's going to be consistent with our other findings as we descend closer and closer to the cervical rib. So at C5, C6, I found either decreased motion. In other words, if these measurements are off, and the total angular motion is actually like 0 or maybe a slightly positive number. What if this was 1.7 degrees in the other direction, in the positive direction? It's still close to 0, so it's very little total angular motion. So I described it as decreased motion with the potential or the possibility that this may even represent an area of anti-directional opposite or aberrant motion, which would be consistent with a cervical hyperflexion injury and ligamentous damage at that particular segment of the spine. This is a known phenomenon that these vertebrae have suffered a loss of motion segment integrity, and here this is the radiographic finding which supports a permanent impairment rating for this level of the spine, particularly in the context of aberrant or anti-directional motion. And then finally at C6, C7, where C7 has the attached and fixed cervical rib, there was 0 degrees of total angular motion, so I concluded that this represented an area of decreased or absent angular motion. So we have 3 levels of the spine of varying losses of intersegmental spinal motion, and this qualifies for permanent impairment under the DRE category 4. So let's take a quick look at the DRE category 4. So according to the AMA guides here on page 378, they tell us in the upper cervical spine, which is occiput to C2, so that includes the segment of C1, C2, there is little flexion extension, while the lower cervical spine permits increasing flexion extension movements from about 10 degrees at C2, C3 to 20 degrees at C5, C6, and C6, C7. So it wouldn't be unusual to see a 3-degree increase at each spinal segment as we progress down the cervical spine. Well, in our case, when we get to C5, C6, we're seeing anti-directional or 0 degrees of motion. And at C6, C7, we're seeing absolute 0 degrees of intersegmental motion. So considering those 2 levels and even the 1 level above it, C4, C5, which showed decreased total angular motion, we're having a significant loss of function of the cervical spine in terms of loss of motion of the individual segments of the cervical spine. So let's go to the DRE categories for the cervical spine. And we get to those on page 392 here. And they tell us in table 15.5 that alteration of motion segment integrity is defined from flexion and extension radiographs as loss of motion of a segment due to a developmental fusion or successful or unsuccessful attempt at surgical arthrodesis. Now, this particular examinee doesn't have a developmental fusion and has not undergone a surgical arthrodesis, but does have near complete loss or complete loss of multiple motion segments of the spine. So this examinee qualifies for permanent impairment under the DRE cervical category 4 at 25 to 28% whole person impairment, either under the strict application of the AMA guides or certainly under Alvarez and Guzman, if you feel that the examinee doesn't exactly match this description relating to a developmental fusion or a surgical arthrodesis, but by analogy to developmental fusion, you can make a case that the examinee has a developmental anomaly, which results in a fusion, an effective fusion, an analogy to fusion, a fusion of the C7 vertebra to the first rib and to the first thoracic vertebra through this anomalous cervical rib, and you can provide for an impairment rating directly out of table 15.5 due to the DRE cervical category 4. So doctors, I hope this helps you. You know, providing for permanent impairment due to loss of motion segment integrity begins by obtaining the necessary cervical spine radiographs. And many qualified medical evaluators do not take the time, the effort, or the energy to go through the process of obtaining the necessary diagnostic studies, and I understand this. I understand this completely because, trust me, I can tell you from experience that getting the necessary diagnostic studies in time to produce your QME report is a royal pain. It's a problem. It's a big deal. It's a hassle. But notice the benefit that was provided for this particular examinee by the qualified medical evaluator who actually went through the anguish that it took to get the necessary diagnostic studies, because without the necessary diagnostic studies, this examinee would never qualify for an impairment rating as high as 25 to 28%, because there would be no way to provide that impairment rating without the flexion and extension radiographs. So this examinee otherwise would qualify probably only for a DRE category 2, certainly wouldn't qualify for a DRE category 3, because there was no findings for radiculopathy and not even complaints of radiculopathy. So the impairment rating in this case quintupled. It went from 5 to 8% under the DRE category 2 to 25 to 28%, a quintupling of the permanent impairment rating for actual impairment suffered by this examinee. This examinee has a loss of intersegmental motion segment integrity of at least 3 segments of the lower cervical spine. And it was the opinion of the qualified medical evaluator that the cervical ribs created an anomaly at the lower cervical spine, which was a pre-existing condition that was previously asymptomatic. Now, we don't know if this examinee had a prior stiff neck or feelings of tightness in the neck or any symptoms at all in the neck, but certainly this C7 segment of the spine with this supernumerary rib, with its variable attachment and fixation to the first rib, creates a fixated segment and a loss of intersegmental motion at this segment, which then suffered injury with the front impact hyperflexion injury. And then the segment above, the C5, C6 segment, apparently took the brunt of the blow of that injury, because intersegmental motion angular measurements at that level demonstrate aberrant antidirectional movement at that segment. So this is a segment of the spine that has ligamentous laxity and loss of its normal motion segment integrity, according to the values prescribed and described in the AMA guides. So this is an examinee who truly qualifies for this impairment because he suffered a significant loss of function of the cervical spine, and he's certainly going to have problems with it long into the future. So I want to encourage you in each and every case to order the necessary diagnostic studies that are described in the AMA guides, no matter what hassle it presents to you, because it always provides information that will contribute to your final opinions and conclusions, which always have as their intention, should always have as their intention to provide the most accurate description of the examinee's impairment, or the most accurate description of the examinee's actual condition. So I want to encourage you to take the time, take the effort and the energy necessary to obtain the necessary diagnostic studies. So I want to thank you for taking the time to join me on today's discussion. I look forward to being with you on our next discussion, as well as we continue in our current and ongoing series entitled The QME's Clinical Rounds. For now, this is Dr. Perry Carpenter, wishing you best of success in your career as a qualified medical evaluator.